This video is about the inguinal canal. We're going to discuss the anatomy, as well as highlight the concepts to better understand that anatomy and how this relates to hernias.
So let's look at the groin. If we start with the anterior superior iliac spine and the pubic tubercle with the inguinal ligament running between the two. And we'll come on to talk about exactly what the inguinal ligament is in a minute. So the first key concept is to imagine the inguinal canal as a cuboid between the ASIS and the pubic tubercle.
The anterior wall of the inguinal canal is formed by the external oblique aponeurosis, which has a small split at the medial end, which forms the superficial ring. The inferior edge of the external oblique aponeurosis curves backwards to form the floor of the inguinal canal with its rolled edge, like a gutter. This is, of course, the inguinal ligament. The posterior wall of the inguinal canal is formed by the transversalis fascia. At the midpoint of the inguinal ligament, that's halfway between the ASIS and the pubic tubercle, there's a defect in the transversalis fascia, which is the deep inguinal ring.
Before we come on to the roof of the inguinal canal, we need to consider another concept. The deep and superficial inguinal rings create potential weak spots in the anterior abdominal wall. The roof of the canal creates a clever mechanism to address these potential weak spots.
In the lateral part of the inguinal canal, the internal oblique fibers are situated anterior to the deep ring, reinforcing it. These fibers arch diagonally to lie posterior to the superficial inguinal ring, where they form the conjoint tendon with the transversalis fascia. Medially, they reinforce the superficial ring.
Now let's consider the contents of the inguinal canal. First of all, there's the vas deferens, accompanied by the testicular artery and vein, the vein, of course, forming the pampiniform plexus. There are also a few nerves we need to consider. The first nerve encountered during an open repair is the ilioinguinal, which runs just underneath external oblique and runs inside the inguinal canal but outside the spermatic cord. The genital branch of the genitofemoral nerve passes through the deep ring and forms part of the spermatic cord. Finally, we need to consider the iliohypogastric nerve, which, while not part of the inguinal canal, is at risk during suturing of a mesh. And finally, we can consider hernias. An indirect inguinal hernia passes through the deep ring and along the canal before exiting through the superficial ring, whereas a direct hernia bulges through a weakened transversalis fascia in the posterior wall. The inferior epigastric artery is situated just medial to the deep inguinal ring, and as such serves as a landmark to distinguish direct from indirect hernias. Thank you for watching. My name's Dr. Alexander Brown, and look out for more of my 5-minute tutorials.